Good morning. This is a dream come true for those of us who helped to found this organization, to see all of you here today. And it's really an incredible pleasure to welcome you to what I think is a unique conference funded entirely by those who have attended and supported by an organization that is 100% donation funded. Our mission, as you know, is to bring parents support, to advocate for better treatment and research, and to provide informational evidence-based treatment. And there's no one who is more qualified, I think, to be our lead-off scientific presenter than the person I have the pleasure to introduce. Dr. Locke doesn't know me, but I know him. So, like many of you, I became involved because my daughter was ill. She received, initially, the kind of treatment many of you might have received. And after 3 months of treatment, in which I was told not to be the food police, she was worse and not better. I had a cousin who was a pediatrician who trained at Stanford, and she said, you know, there was this guy who was there when I was there. I think you ought to see if he's written anything about this. So I went out and I got the book that my husband and I came to refer to as the Bible. I went creeping into our therapist's office. I said, have you ever heard of this stuff? And she said, well, yeah, but you know, there's not a lot of evidence it works. Well, given my background, I went and I looked again and I went, wow, here's somebody who doesn't use the word eclectic, who actually talks about randomized clinical trials. So I called Stanford on the phone, and Dr. Locke answered the phone. Now, I probably shouldn't say that because you're all going to now try to call him. But he answered the phone himself, and I said, I'm just trying to get some information about your program. And he said, well, I'll give you the number, but why don't you tell me about your daughter? I've never forgotten that conversation. I wish I'd listened to him then. I wish I'd listened to him when he said to me, if your daughter is still that ill, don't worry about her relationship with the therapist. Worry about her relationship with the eating disorder. I wish I'd listened to him sooner. But eventually I did take my daughter to Stanford. My daughter did recover because of the care she received at Stanford. So in my mind, Dr. Locke is a star. There's a lot of leading lights in the field here today, but I have to tell you, this man and the work that he did along with the individuals that he's collaborated with, I think have brought this field really out of the dark ages and into the light. So thank you, Dr. Locke, for everything you've done, and I hope you all enjoy learning from him as much as I have.
Well, thank you. That was very, very kind. You know, I do answer my phone. I still do. And I still answer my emails. It's a very frightening thing, actually. Yes, I still do that. I'm trying to make this. Oops, I'm back. Whose phone is this?
She wants you to have the phone.
Thank you for inviting me to speak at this conference. It's very moving to do it and wonderful to be here. What you see in front of you is a pile of rocks. And the pile of rocks is there because when I got my syllabus, I found out the title of my talk was given to me, actually. I had the topic in general we had discussed, but rocky terrain was the sort of a special way of describing what I'm going to be talking to you about. I don't know what where this particular rocky terrain is, but I myself think it's at the top of Mount Talak, which is the largest peak around Lake Tahoe. And it looks like this at the top. I climbed it for a second time this summer, and you can really hurt your toes. So the organizers asked me to talk about challenging ideas about how professionals look at families. This is a topic that I talk about directly a lot. I mostly talk about evidence and about science, and then teach people strategies and techniques, but I'm always trying to actually take this particular dilemma on when I'm speaking to any group, really. So I'm going to very briefly, I only have about half an hour to speak, and then you get to ask questions of me, which is terrific. I want to tell you a little bit about how I think we got to where we are in relationship to families. And then I'm going to talk a little about what happens to professionals in their training careers and what families expect. And then maybe a little bit about how we might move forward. But there are people here clearly on the program who are going to be much better at thinking about that last piece. Just to remind you, this fellow is Leo Kanner. This is to tell you we are not alone, or have not been alone. Leo Kanner wrote about autism. The child is exposed from the beginning to parental coldness, obsessiveness, and a mechanical type of attention to material needs only. They were left neatly in refrigerators which should not defrost. Their withdrawal seems to be an act of turning away from such a situation to seek comfort in solitude. This is in 1943. Leo Kanner was one of the founding voices in describing autism, and his point of view on autism was elaborated even more by Bruno Bettelheim, the University of Chicago psychiatrist. The difference between the plight of prisoners in a concentration camp and the conditions which led to autism and schizophrenia in children is, of course, that the child has never had a previous chance to develop much of a personality. So parents always, unfortunately, Pace, Lara, mothers usually is what it means. Fathers seem to get a pass a little bit. We're blamed for the disorder of autism. This fellow is Bateson. He said about schizophrenia, we suggest the double-bind nature of schizophrenia results in a place of a child in a position where if he responds to his mother's simulated affection, her anxiety will be aroused and she will punish him to defend herself from closeness with him. So the theory of schizophrenia here was mothers gave double-binding messages. You could never love or you would be rejecting. If you rejected, you were loving, and always it was an unbearable conflict imposed upon the child by an uncaring mother. So both autism and schizophrenia were disorders, this is 1956, disorders that were firmly blamed on parents. Turning to eating disorders, which were first described a long time ago, but in the medical literature, and by Sir William Gull wrote this quote, the patients should be fed at regular intervals and surrounded by persons who would have moral control over them, relatives and friends being generally the worst attendants. And what I want to say about that quote is that there's a lot right about it. The first clause. But, the second piece provided a sort of schema for how to think about treatment for eating disorders for the next 100 years. And that is that relatives and friends should not be a part of that process. Charcot, in the way that the French often do, put things much more succinctly and directly. it is necessary to separate both children and adults from their father and mother, whose influence, as experience teaches, is particularly pernicious. Now, when I give talks to professional audiences, I always ask them to raise their hands if they're parents, and if they think their influence is particularly pernicious on their children. I don't think I need to do that here. I don't know what you got that medal for. This is Hilda Brooke. She wrote, excessive concern with the body and its size and rigid control over eating are late symptoms in the development of youngsters who have been engaged in a desperate fight against feeling enslaved and exploited. And there's a parenthetical, by their parents, not competent to lead a life of their own. And Dr. Brooks' notions about the need, from a psychotherapy point of view, to put treatment emphasis on the individual's separated identity and autonomy, took the ideas of institutional care, which was the predominant way that Charcot and Gull thought about separating patients, into the individual psychotherapist's office. This is Salvador Minuchin. This is a misleading photograph. He's actually kind of a bit of a sergeant in family therapy. Any of you have ever watched any of his tapes, you'd kind of go, whoa. I'm not sure I want to be in therapy with that guy. Not that he wasn't insightful or helpful, I don't mean to imply that, but he did define the disorder of anorexia specifically as resulting from or being maintained by family processes associated with being over-enmeshed, rigid, anxious, and over-involved. And these qualities, which he observed in the families of patients he treated, were interpreted by him as needing to be addressed in order to cure the patient herself or himself with the disorder. I should say that, one of the things I always like to emphasize is, he might have actually seen a lot of those qualities when he was treating families. I was originally a consultation liaison child psychiatrist, and I would see families whose children were in the ICU or who had cancer, and they look like that. And if anyone has a desperately ill child, you do get a little bit more anxious. You do get a little bit more involved. And you do maybe get a little less flexible in your thinking under that stress. And you could appear, therefore, enmeshed. So the notion that this was either unique to anorexia, which he really wasn't claiming, he thought all psychosomatic illness families were like that, but not actually maybe a result of the process of being a good parent. Maybe didn't cross his mind. There was a study that was done at UCLA where I did my own training, which looked at parents and kids of cancer survivors. And these were kids who had had serious cancers in their childhood, 10, 11-year-olds. They looked at them like 10 or 12 years later, looking for symptoms of post-traumatic stress disorder. These were kids who had had surgeries and had lots of chemotherapy and were in hospitals and in isolation and that kind of thing. And they looked for symptoms of PTSD, and they didn't find them in the kids, but they did find them in the parents. And that's because good parents work to shield their children from these kinds of events as much as possible and protect them. So some of these characteristics are the result of what I would call good parenting instincts in a crisis situation. Moving on to some of the dilemmas that professionals face besides the historical ones. You know, when we're trained in psychology and psychiatry, we often are trained in theoretical models. However, most of these theoretical models are untested. They're very interesting. In fact, they're quite enticing, many of them. Psychodynamic models in particular are untested and often strongly held. As a person who was trained in many of these models and who thinks they're very interesting and maybe even uses them sort of quietly when I'm working in groups or with other professionals, I have to say I like them, but I also know that they're limited in terms of, as a scientist and as a physician, I shouldn't rely too heavily on them, but we're taught them. We're very limited about our true understanding of the etiology of anything. And most of the time, we are treating symptoms and trying to limit their impact on function. And that is fine with most doctors for most things. If you have hypertension, it'd be great if we could get to, if you have a particular kind of adrenal problem, we can fix that, great. But if you actually just have routine hypertension, we're going to actually just try and lower your blood pressure most of the time. But the medicine doesn't really address the cause, it just changes the status. But in psychiatry and psychology, we have been truly bewitched by the siren's call of etiology. And you know what happened, right? The siren's call, you crash on the shores of your own love affair with the sound of that music. And that happens fairly often in psychiatry and psychology. We find ourselves having strongly held beliefs about things, whether it's, the notion that refrigerator mothers cause autism. That just doesn't sound right to us anymore. It sounded really right at the time that Kenner wrote that, to him and to a lot of his acolytes. The point is, we aren't very practical or we aren't modest enough, and we should be really more modest about this. Treatment based on these kinds of putative causes, I have examined your family and I think you have some unresolved conflicts between your parents, and that you're acting out on that conflict in your eating disorder, which would be a formulation that would not have been uncommon. So we need to actually get them into couples therapy, and you need to find a way to find your own identity. You know what? Treatment based on that isn't actually based on anything except someone's idea. Now, it may help. I'm not saying it may or may not help. But it is, when you do so, you begin to point fingers. And when you're pointing fingers, as the causes are actually what you're supposing, you're doing harm, or potentially doing great harm. The other thing I'd like to say is that 1946 isn't that long ago. Many of my teachers were trained by people like that, and many people who are in the field were absolutely part of getting the best training available to them at the time as professionals. And therefore, it's not surprising that they believe what they were taught. Turning to, I'm a child psychiatrist, so I want to say just a word about psychiatrists. They may be particularly challenged with working with eating disorders. Many training programs don't have opportunities for psychiatrists to work with eating disorders in their programs. Psychiatrists tend to want to use medications for things. Most of the time when kids come to me from their pediatricians or other psychiatrists, I am taking them off of medicine first. Not that I don't think medicine could be helpful, but the fact is we don't have much evidence of useful tools yet, and that kind of makes a lot of psychiatrists feel like their hands have been tied in some way. Family therapy training also is hardly done in most training programs in child psychiatry or general psychiatry. And if it's done in a fashion that most of us would recognize as inadequate.
And therefore, a lot of the work with eating disorders is turned over to other professional groups, psychologists and to adolescent medicine doctors who also are trained in psychology, psychiatry, or family therapy. And there are very few child psychiatrists, and these disorders often occur in adolescence. So it's a particular hardship for child psychiatry, I think. Psychologists, they worry about these disorders from a different perspective. A lot of them want to avoid them because there's all this medical worry that is associated with them. These kids can get very sick. Their potassiums can go very low. They can get dehydrated if they have bulimia. They can start bleeding. There's a lot of things that anorexia. They get this terrifyingly low weight and other kinds of consequences, and they could die. That's something like, oh wait, now maybe an MD should be involved here. So they begin to push them aside. There are also many more training programs in psychology than in psychiatry or child psychiatry, but even there, specific learning about eating disorders is rare. So there's a lack of exposure and experience. And there may be, and I certainly know this from talking to a lot of people, there's kind of a preference for those who work with kids. We like kids. We like adolescents. We kind of would prefer them to parents. Sorry. But there's kind of a truth to it. We go into the field because we like to work with this age group, and when but that's the fun of it. Part is taken away when we do family work. It might seem that way at first. They kind of want to avoid it. About my own development, because I think, this is a conference that I think has a personal valence in it, and that Laura spoke to in her opening remarks, and which I hope all of us will be able to carry forward. I was taught at UCLA by some of the best experts in the field of eating disorders as a resident. I think Walt Kay was also trained at UCLA, so sadly, we both had to undo a lot of things we learned, but I learned it was a developmental disorder, and that parents were over-controlling, and that professionals were better than parents at doing the job. And and furthermore, that institutions were better than professionals. That is, the more, the better, the best of us. Well, that's the way to go. I started right after my child training, I took a job at at Stanford, at running their eating disorder program, which was a bigger program for psychosomatic medicine. And that was the model. Parents, we kept kids in the hospital for 2.5 months. This is in 1993. 2.5 months. They were medically stabilized for about a month of that, and the rest of the time we did individual work with them. Parents could come in for visiting hours, for an hour in the evening. They could never be there at mealtime, because Lord knows that would be terrible if they got involved with the food. The kids worked out their meal plans with incredible poignancy and obsessiveness with the dietitian, who was wonderful and patient and gracious. Her name was Grace. They would gain weight and they looked good, and then we'd send them home and they would get sick again. What were those parents doing? I really was befuddled. They're frustrated by no end. And then I said, well, what are those therapists also doing out there? We're good here. So what are they doing out there? This insular quality to institutions and institutional management is a huge barrier to really moving any field forward, but it was particularly true in psychiatry at the time. We did get a kick in the butt, though, by managed care, and they basically told us, you're not going to be able to keep those kids that long anymore. You better figure out something else. And in California, it came early, and I suddenly had to think of something different. And reluctantly, rather reluctantly, I had read about this treatment developed at the Maudsley Hospital in London, which seemed to me completely crack. Really, seriously. We can barely feed them. How can parents do this? You must be kidding. But I was a scientist, and I looked at the one study, and it said, yeah, they can. It was a small study. It wasn't really that great a study, but it was better than nothing. And it was, for the time it was done, it was a great study. But it wouldn't pass muster now. And the only true of my studies in a very few years, and anybody else's for that matter. So I just want to be clear. The field advances and science advances, and our standard of what's evidence will continue to advance. Anyway, the point is, I said, okay, well, I'm going to try it. And Daniel LaGrange, my collaborator on so many things, came out, and we wrote a manual and tried to do it. And my whole staff, my entire staff, thought I had lost my mind. This is that prophet in his own land period where I was just, crazy man in the desert, We thought you were a good doctor. What can you be thinking? It was a while, maybe 4 or 5 years, before my staff actually truly believed that families could do what I had learned they could do, and which then now you try and offer them something else. Because not all families want to or can do family-based treatment. And I say, well, we have to have alternatives. We've got to think of things too that are other than this. Doesn't always work. And now they've institutionalized family treatment in a way that I'm now kind of going, well, wait now, hold on. It's very difficult to disseminate data-driven treatments. Clinicians resist manualization as cookie cutter and not real world, and they have some grounds for this concern. When you do studies, you have to have parameters around them, and you have to have a certain kind of population that you can say has been predictable and so on. There are lots of system problems that interfere with the use of family-based treatment. The diagnostic groups aren't clearly articulated often. Reimbursement for family therapy may be problematic in some systems, and there are administrative and clinical and physical structure issues. You have to have certain kinds of rooms, and you have to have an ability to see all families together and schedule things. These all change practice, and they interfere. Furthermore, there's a very limited evidence base for how to best disseminate treatments. How do you get them to, but I'm not going to leave half an hour. I told them already. But close. Finally, there are specialist and guild issues and accessibility issues. These truly interfere. One of the issues that comes up all the time with family-based treatment, as a specific example, is the role of the dietitian. And I always feel like I'm going to get pies thrown at me. I actually really like our dietitian. I really want her on our team. I just don't want the role that they were playing being played in the context that it was played when they're getting family-based treatment. So we have to, but that's true for every single professional area. The child therapist doesn't get to sit for an hour with the adolescent and talk about stuff either, at least certainly not at the beginning of therapy. And the psychopharmacologist doesn't get just to give medications. Perhaps one of the biggest barriers though is accessibility. And Daniel and I have tried for a long time to figure out how we can more quickly get the ball rolling across everywhere. Here's the treatment, please try and use it. And we do a lot of trainings, it's quite exhausting. But nonetheless, it never seems to, there are whole pockets of the universe that have no access at all. The southern United States, essentially, like if someone called me, and people do, and say, I live in Baton Rouge, do you know a therapist? And I don't. Now, there may be one, but I don't know one, and I haven't trained one to my knowledge. Jennifer Couturier, who is a child psychiatrist in Toronto, Canada, and worked with me for a while, just presented at the American Academy meetings this past month on a little study she did of 40 therapists, and she was talking to them about particularly family-based treatment for anorexia, and 65% of them discussed their reluctance to commit to evidence-based practice, saying one size doesn't fit all. 65%. But the good news is 75% felt it was imperative to involve parents. Now that's a good piece of news for me. I don't know exactly why they thought that. They also felt that in their healthcare system, and this would be true in ours, I believe, too, in the United States, and I know that people from around the world and all healthcare systems do vary a lot. But whenever you're trying to put in practice a particular kind of treatment, you do need administrative structure. One of the things that was written was, I think that's where the individual organizations have to make a commitment to supporting their staff, because if they're working in eating disorders, then they need to actually provide their staff with the training so they can deliver the best treatment possible. And right now, that doesn't happen very often. And also that the entire team, including the administrative team and the business team, need to understand the implications of taking on a particular model of care. Finally, working with families for a long time, and I know that many families are really sometimes themselves reluctant to embrace evidence-based practice because they want to know the cause. They're a bit like the therapists in that regard. They want to know why this happened. I always ask people in a professional audience at an eating disorder meeting, I say, okay, how many of you know the cause of any patient's anorexia nervosa? And no one raises their hand. That's because they know in their hearts they don't know. Doesn't prevent them from acting. But parents want to know, as we all might want to know, because we don't want to make a mistake. We want to do it right. We don't want to have the same thing happen or something like that. So there is a motivation, but it's very, very hard to step back from that and say, let's just look at the problem and deal with what's in front of us. Guilt and blame, parents, I say, if your kid falls in the playground and you're at work, somehow you're responsible. They didn't have breakfast, they should have been wearing long pants that day. You can come up with a bunch of things, but as a parent, there's kind of a almost gut reaction in many of us that somehow we're the cause of it, and that is both overt and covertly held, and so that's a dilemma. We often feel unprepared and unable to take on this problem at home because we think we've tried our best to figure it out, and we often have, but at the same time, we haven't had much help with it, and thinking through in a consistent way is quite different, and getting prepared. And a lot of times, this wish to sort of say, can you take care of this, please? I can't do it anymore, is really, really, really profound. And as Laura said at the beginning, and probably will be echoed throughout, not everyone responds to any one kind of therapy. And we should not expect that for anything. In behavioral medicine, if you get a 60% response rate, that's amazing. Even with antibiotics, you are looking at probably 80%, which we think about as being the first course for a lot of things. So we need to have realistic expectations. So moving forward, I thought about, this is a slide I use in my training of patients and of therapists in family-based treatment. And this is the so-called fundamental assumptions, which I named fundamental assumptions sort of by accident. But this agnostic view, non-authoritarian stance, empowerment, externalization, and pragmatic focus. I thought, well, you know what, this actually applies to what we need to do moving forward. We need actually to embrace agnosticism and be more humble in a non-authoritarian way. We need to empower ourselves as professionals to learn and to accept that we still need to continue to learn. We have to accept consultation and externalize the problem of our learning, separate the disorder from the treatment that we need to do. I like these little sayings as ways, because I think agnosticism is so clearly a key thing here that helped me remember, and maybe you remember, to practice. It sounds very Zen-like. It's not DBT, Zen-like. Practice forgetting what you think you know. Clarence Darrow said, "I do not consider it an insult, but rather a compliment to be called an agnostic. I do not pretend to know where many ignorant men are sure." That is all that agnosticism means. And Carl Sagan, the scientist, extraordinary claims require extraordinary evidence, and there's frankly not extraordinary evidence. Bertrand Russell, the English philosopher, "In all affairs, it's a healthy thing now and then to hang a question mark on the things you have long taken for granted." This one I love from Henry David Thoreau. "If you see a man approaching you with the obvious intent of doing you good, you should run for your life." And in Ireland, Quentin Crisp, the social commentator, "When I told the people of Northern Ireland that I was an atheist, a woman in the audience stood up and said, 'Yes, but is it the God of the Catholics or the God of the Protestants in whom you do not believe?'" And there's an awful lot of that in the field of psychiatry and psychology. This is a nod to Daniel. He doesn't like spiders, and he uses this to externalize anorexia. It's this big Amazonian spider that hovers up in the jungle and plops down. It's a terrifying image. And so that's a lot about how I think therapists sometimes feel about changing how they work. And it's very terrifying to actually really put into question what you've been doing for a long time. And that's one of the resistances we face in challenging in that rocky terrain. We should also anticipate, this is a business model J-curve, what change really is likely. You'll notice that what we hope is that red, we started, it's all going to go like this. But in reality, what happens, and this is the truth of the matter, is that you actually have a J, and there's usually a dip, a very perceptible worsening before a bettering. And I do think we're kind of somewhere where that little J-curve box is now. We're kind of moving upward, but we haven't fully gotten to a sense of approaching a desired state. Those of you who know me might recognize this. This is a sandhill. Early on, I was treating a family, and the mother, after about 10 weeks, said, "Oh my gosh, I figured out what this is like. This is like climbing a sandhill. If I back off even a little bit, I'm going to slide back down. It's going to get worse." And I just thought she had nailed it, perfectly gotten what it's like. And the thing about a sandhill is you do need to keep moving, or you will slide. And that, to me, this is ground up, rocky terrain, right? So we're making progress up this hill. But we really can only move forward by empowering families with the knowledge that you're going to be getting, you already have. People often ask me in interviews, why are we in such a poor state about science in this field? I said, well, we were in a poor state about autism a few years ago. There's so much stigma, and that may be our biggest obstacle. The fact that parents and families are still stigmatized for anorexia and bulimia and related disorders, we've escaped that. Parents have overcome that in some of the other disorders most of the time. We need research and dissemination, and we need to target the developing professionals in their schools of psychology and psychiatry. And hopefully if we do, this is the top of the sandhill, we may feel like these two do. And with that, I'll stop and take questions.